Welcome everyone to this episode of your Freedom Hub's Free Market Cash Patient. I'm your host, Jeff Cantor, along with Charles Frohman. We're definitely sponsored by the Marketplace for Health, Wealth, and Freedom, and we're excited to have you here tonight. We are recording these for posterity, and I'll kind of show you how we archive these. We're definitely sponsored by the Disruptors Intersection because, again, that's the whole goal of what we're trying to do here is disrupt the status quo to get into something much more meaningful and better for us. Now, the other situation is the fact that there's a lot of information out there, and not everybody's figured out, but there is a problem, and it's a big one. But it's become extremely obvious, and so the workaround is very obvious too. But it's a function of us taking that action as individuals, doctors, and consumers, because there's no government or insurance. No one's going to want to help you get away from what's making them money and helping them maintain control. We just need to walk away, and guess what? Then they suddenly go out of business, or they have to conform to what we prefer. And again, the information, there's a lot of disinformation and mixed information and who do you believe and all the rest of it. And a lot of the stuff doesn't even get out there to get an airing so that people can even make an intelligent decision. Now, just as a little quickie sidebar, we have another show we feature a little earlier in the day, so we would encourage you to check that out. And this is a similar mentality where it's covering all these other issues related to your personal freedoms, just not so much on the medical side of things. And as I said, we have a great website. It's the two addresses take you to the same place. There's the mphealthwealthfreedom.com or then the acronym for it. That's where we're going to find these videos. So let's shift over there for a quick second. When you come on over here, you'll see there's a lot of great drop downs and things to scope out. But under the home tab, you'll see there's the webinar tab. That's what we're talking about tonight. And then the continuing the conversation. Let's jump to that first, though. So if you click on that, it takes you over here. And why we feature this is because after we have such a great guest, it's usually just the beginning, not the end. So here's your way to connect with these people and get involved with them in one way or another and help further these various causes because it's just that important. And then, as I indicated on the webinar page, let's zoom down to the bottom a minute. There's the breakout of the two different events we just discussed. And then here's the upcoming guests. And then most importantly, here are the links to the ones that we're going to be recording and releasing over the weekend on all these different platforms. And we keep adding them as they become available. So here's like the one that's up on Brighteon as an example. And you'll see there's a whole slew of stuff goes back for a long, long time. They're all really fantastic, I have to say. And we really want you to participate. Now, also important because we're talking about our health is on the health tab. There's a bunch of things to drop down, but the most important one we want to mention is the idea of this app that's come out that allows you to connect directly with doctors. So it's very pertinent for tonight, as typically it is. Because if I'm a consumer and I'm looking for a doctor, how do I find somebody if I don't have insurance or don't want to be participating in insurance or even have insurance, but I want to get a better price? I want to go shop around like I would on Amazon. So the same thing here. This is kind of like the Amazon for finding a doctor. But what's great for a doctor, when I book the appointment, I prepay for it, sits in an escrow account. But now when I visit the doctor, the money's released immediately. They don't have to wait for a third party to pay them and be discounted or not paid what they wanted or should. It just solves all of that problem and allows the market to really function. So we're really excited about that. So on that note, let's shift into today, and I'm going to have Charles do the honors of introducing our guest today.
Gladly, Jeff and Dr. Wallen, welcome. It's good to have yet another weekly webinar on the independent specialist physician. We've had so many over the couple of years or so. Jeff and I have hosted this cash patient free market webinar. We definitely are sold on this aspect of the market, and it wasn't really our first purpose. As Jeff and I got into sharing as an alternative to insurance, pretty soon we realized that the way we were empowering our members to pay the bills was via giving them cash and helping them shop for price and quality. So a friend of mine, John Goodman at Forbes magazine, featured us along with other sharing outfit alternatives to Obamacare as the main one that was really empowering price-sensitive shopping. And given my background going back decades in lobbying and advocacy, making patients shop on price is one of the prerequisites to a better market. You got to have that vigorous supply and demand curve. And if the demand side patients start shopping on price or quality, you're never going to get a real efficient market. Problem is, a lot of doctors are used to what they know, the reimbursement from insurers or even employment in the hospitals. And for the pioneers like Dr. Wallen, who are trying to operate, in his case, urology on a cash basis, it's not a real lucrative market at first, but eventually it can be if you market it right. It certainly cuts your overhead, and it definitely allows you to really fulfill the art part of medicine, which so many doctors crave. Otherwise, with the credentialing and the pressure to standardize with insurance and hospitals, you don't get to really maximize the fullness of the art of your field. Jared is an entrepreneur. He's also in real estate. He really knows his urology, specializes in infertility, anti-aging, all the problems that come with your plumbing. He knows it all. But apart from his specialty, it's really what he's learned in his effort to be an independent physician, which is why he's here tonight. He's got an MBA. He has worked in administration in hospitals, so he's seen both sides of it. So he can really speak to all the pros and cons of the future of healthcare where the doctors are independent. So that's the intro, Jeff.
All right, very good. Well, Jared, on that note, I'm going to release the screen to you.
Perfect. Just get this going. All right, perfect. So good evening, everybody. Thanks, Jeff and Charles, for the introduction and having me on the show. Ultimately, I'm going to dive deep into a lot of the problems because I think it's important to review those, and then we'll certainly talk about the options that are out there to help folks and how it's affecting patients, how it's affecting doctors. But I think the reality is, if I can convince you that empowering both physicians and patients and simplifying the system as a guiding light to reform and to finding a better way for medical care, then that's exactly what you should leave here with, because that's the reality of the system. It's so complex, it's so big with bureaucracy that there's a significant amount of money going elsewhere outside of the patient's pocket, outside of the physician's pocket, and that's where a lot of the problems come from. And so let's see here. There we go. All right. So just a quick little background. I grew up in a very small town, small village, actually 6,000 people, Roscoe, Illinois, blue collar parents. I had 3 years of management experience prior to med school. I basically leveraged about $400,000 for both college and medical school, which is significant. We'll talk about the costs of medical school and education with the goal of the dream of providing the highest value, lowest cost care and running a small business. Obviously, to some extent, actually, I was just in a dermatologist's office here in town yesterday, in fact, and he was like, man, you really should have been around about 20 years ago because that would have been perfect. Nowadays, it's very tough to do. And also, I did, unfortunately wasn't able to do that right out of training. And so I did work for a corporate hospital system for a while. And that's why the last line is there. I'm a recovering, silenced, devalued, and disenfranchised corporate pawn. Because the reality is that more physicians than not are now employed by corporations, and to a large degree, you're silenced from whether it's safety issues, whether it's even talking about COVID or what have you, all these different things. If it's not in line with the company line, you got to be very careful, because otherwise they will potentially come for you and get rid of you. Actually, there was just a physician in Montana there was an article a few days ago now that was released after 24 years of service. Actually, now currently he's in lawsuit with the hospital system, but also a bunch of the people in the town actually tried to sue the hospital as well, because they were like, there's never been any complaints about this guy. He's been great. He's always been taking great care. For one reason or another, they decided that they were fed up with him and let him go. And unfortunately, unless you're the one that owns it, unless you're the one that's in charge of the corporation, that's, the reality of being an employee. And so that's obviously a problem for physicians, because we should ultimately be the advocates for patients. And so right now, healthcare is, like Jeff had showed earlier, there's multiple people or entities in between the physician and the patient. The doctors, potentially the government, the insurance, the employers, all can potentially be a barrier to care, where it should be patient and physician. And that's the reality of it. Obviously, there's a decent amount of fear around, well, how am I going to pay for this if I get sick? Or how am I going to do that? Or what am I going to do if this? And obviously that's where, to some extent, insurers and the rest of the system kind of plays off of that, and basically is able to take advantage of both patients and to some extent physicians as well. And so ultimately, if we can get rid of that, that's the best place for us. Patients, unfortunately, are already being harmed significantly every day by terrible systems in medicine and in general, but in medicine, certainly. The best way I can describe it to you is that, systemic problems are like car crashes, physician problems are like airplane crashes. And what I mean by that is that physician problems get far more press, but systemic problems kill or harm far more patients on an annual basis. I can give you any number of opportunity or of examples of that. I mean, I had patients that were asleep on a table for 30 minutes because the hospital system didn't have routine surgical instruments that we basically use for the exact same routine cases for kidney stones or a very common pathology in hand, and they didn't have it cleaned and ready for the case, yet they put the patient to sleep and then told me about it afterwards. And so I'm sitting there, if that was my patient, my parent, it was my patient, but if that was my parent, or family member, I wouldn't be very happy about that. There's certainly risks of anesthesia, and the longer you're under anesthesia, there's certainly risks associated with that. That's just one example, but even more recently, I had a patient that was, transferred from an outside ER for a problem. I got the patient seen and booked him up for surgery. And then the next thing I understood was that the patient's insurance company was saying that he needed to be transferred to a different hospital because this particular hospital that we already transferred him to was out of network. And so obviously that's a delay in services for the patient. Certainly it's probably going to be an increased cost. I mean, potentially a second EMS transport and obviously more consultations and care from a different hospital system. I mean, that's harm in and of itself from a financial standpoint, certainly. And so obviously there's many examples, but we'll skip on to move on to some other stuff. This is specifically a study out of 2011, which basically evaluated the top 100 hospitals and their CEOs and whether or not they were actually clinically oriented or basically didn't have really any clinical training in medicine. And they looked and tried to evaluate for the best, outcomes, the best quality, et cetera. And they found that actually those hospitals that were run by folks who had clinical experience had 25% higher quality scores than those who were not run by folks or who were run by folks who did not have clinical experience. And so, ultimately, the issue with that is that I would like to point out is that right now in our current system, there's actually a moratorium on physicians owning hospitals. And so physicians actually cannot own hospitals. They could still potentially be, chief operating officer, COO or CEO or what have you, but they can't collectively own and operate hospitals that way. And so, we're left to have this system where we basically guarantee that big corporations are going to be in charge. And we'll talk about a little bit later. Unfortunately, these big corporations aren't always in looking out for the best interests of us or the patients or, or their pocketbooks even. So that's a problem. This is a recent social media post from Robert Kiyosaki. For those of you that don't know, he's a real estate guru and also financial guy. He basically, with this little meme here, healthcare is basically run by accountants now. And ultimately, they basically are making decisions about whether or not people are living or dying based on, whether or not they're getting care, whether or not they're being covered for care. Ultimately, if a lot of times, patients in this system in America, we love our comprehensive health insurance where, we have to pay the least amount possible and we can go out and spend our money on whatever else we want, but don't really have to pay for it. But unfortunately, that gives up the power and control of decision making, and ultimately, potentially, certainly affects a lot of us or a lot of patients down the line. This is actually a quote from Josh Kaufman. And this actually has nothing to do with medicine, but I think it's very relevant. It's from his book, My Personal MBA. And it's actually, the quote is the administration aren't supposed to make the hard decisions. They don't know enough. The important decisions are made by the individuals who have the most direct knowledge and experience about the area in question. From a medical standpoint, whether that's the nurse about a nursing problem, whether that's the doctor about a medicine problem, whether that's whomever, I mean, obviously patients are experts in who they are and who their body is and what their body usually is like and how it's different and the symptoms that they're feeling. And typically they come to physicians with those symptoms and are able to communicate with us so that we can do our best to help them with whatever problems they have. And unfortunately, a lot of times we're seeing through either prior authorizations or denials or, just the hoops that and items that physicians have to jump through to get authorization for patients. I mean, I just had a letter from United last week about a medicine that I prescribed for a patient with an enlarged prostate. And they basically, this medication I've been prescribing for the last, basically 8 years in practice for this subset of patients who also have, another symptom that we call urgency. And ultimately, they basically said that the medication is contraindicated and they weren't going to approve it for the patient, even though it's actually pretty cost effective and cheap. They're basically practicing medicine without a license. And to a large degree, there's this thing called a peer-to-peer where I can basically appeal their denial and talk to somebody who's a physician on the other end of the line, potentially a physician. Sometimes they're a non-physician provider like a nurse practitioner or a PA. Sometimes they're not even, I mean, certainly most of the time, I don't think I've actually ever spoken to a urologist. So, ultimately, sometimes it's a pediatrician, sometimes it's a family medicine doctor, what have you. The reality is that if they don't actually have board certifications in urology, they really shouldn't be making decisions about your urology care. And that's what your physician is for in the first place. But obviously they need to, the main way a lot of these corporations or even the government, Medicare, Medicaid can basically cut their costs is by denying and rationing care. And so that's a problem for patients because obviously that even though you have insurance, you don't necessarily have access and actually have care. And so this is just a graph that I took from the Citizen Health folks. Brennan and John Chamberlain are good buddies of mine. Ultimately, this was a graph that they had made that looks at the growth of administrators since the late 80s, early 90s in medicine. And what you can see from this graph is that the reality is that the incremental increase in price, the yellow line, has paralleled the increase in administrator growth. And you can see the very bottom, the light blue or teal line, the physician growth has almost been stagnant, yet we've had this significant increase in administrators and also significant increase in costs. Potentially administration accounts for something like 34% of the folks that are the monetary value of our medical care. And yet there's studies that show that administrators don't provide any value to you from a clinical standpoint. And so, the question then becomes, if they're not really providing you value from a clinical standpoint, what exactly are they doing and why are they a part of the system? Especially if, we could certainly teach physicians a little bit about business and have them, kind of run things. And we already talked about how, physician-run hospitals are actually even better from a quality standpoint. So that brings me to the next point. Ultimately, there's 4 million small businesses in the United States. They employ 31 million people. And after COVID and everything that's happened in the last year or so, they certainly need your help now more than ever. But that also applies to physician practices. There's been a significant problem with physicians being bought out by big corporations, by private equity, by hospital systems, and actually even the Obamacare, some of the regulations and rules that came about. And remember, the part of that administrative growth is growth in rules and regulations, right? And so all of a sudden the small business independent physician, to some extent, you just can't keep up with that anymore, or the overhead becomes so high. Actually, a lot of folks that are in the cash market or the direct pay market, basically cut their overhead by somewhere between 30 to 40% by not having to deal with, all the silliness and all the paperwork and all the hoops to jump through with the insurance companies. And so that's a huge problem. Overhead usually usually is a large portion of your salaries for your employees, and then, whatever durable equipment you need. And obviously, if you're adding 34% just to add a couple extra employees to do more paperwork for the government or for the insurance companies, that's a significant barrier to folks, staying open and continuing to practice in their own independent practices. And I hope by the end of this, I convince you that the highest value, lowest cost care you're going to find on the market is through an independent physician. Through a non-corporation, obviously some of them are incorporated. That's another tax difference and liability difference. But from a non-large corporation, the small business independent physician is going to be your highest value, lowest cost care. And so, obviously there's a significant amount that's stacked against physicians to be able to continue in that nature. And unfortunately, that means that private equity groups are buying out physician practices. Hospital systems are buying out physician practices, or, unfortunately, some physician practices are closing. And so here's just one example of that. Actually, Optum, which is actually a subsidiary of United Healthcare. I know I'm picking on United Healthcare a little bit, but unfortunately, they have some activities that are essentially predatory in the healthcare market right now. But they basically own 50,000 physicians right now, and they're expecting to add another 10,000 this year in 2021. They are actually the largest independent employer of physicians at this point in the United States. If that's not a conflict of interest where an insurance company owns physicians and basically can control them, I'm not really sure what is. And so, I'll just leave it at that. But, that's a problem. And this is actually a tweet from a solo doctor that actually was just this morning. So I thought I would add it. I didn't get a chance to get his permission, so I blocked out the name and such. But his tweet is basically, as a solo doctor, the amount of regulations that I have to keep up with is mind-boggling. My mind is spinning just from the payroll and the malpractice premiums, let alone everything else. And this is in response to some new regulations that just rolled out in early April. And the problem is that, again, it just adds more people that you either have to bring in as employees and increase your overhead further, which makes it harder to keep profits rolling in, to keep the business open. Remember, at some point, I think that, unfortunately, it seems like there's a bit of a disconnect where people don't like to see physicians make money. And people, I think, classically always think that physicians, make a lot of money and what have you, which I think that's, been significantly dwarfed in the most recent years. And we'll certainly talk about that in a bit. But, the reality is if I have a surgery, I want all the money that I'm paying going to the surgeon and whoever else is taking care of me, and whatever costs I need to cover for the facility. I don't really want to be paying, profit, shareholders of United Healthcare, or name it, whoever, Anthem, Cigna, whatever you want to talk about. I'd much rather pay the people that are taking care of me and doing their best to help me rather than anybody else. And unfortunately, that is, it's a consideration, because that's part of the reason that independent physician practices are closing, because they just can't keep up with the amount of costs and the overhead. And obviously that's something that we certainly have to look into to try to reverse the trend. Actually, I think Charles posted on LinkedIn today, and there was a gentleman that commented and asked about, the amount of physicians that are being absorbed by hospital systems, and if there's anything that's being done in an organized fashion to reverse or stall that trend. And unfortunately, I don't think so. Actually, I think, the reality is even COVID kind of accelerated that. Actually, last year, 8% of US doctors actually closed their practices. That's 16,000 fewer physician practices throughout the United States. And actually, there was a Medscape survey at the bottom there that you can see where actually 25% of physicians actually are now considering to retire early because of, stressors from COVID, but also just the climate of medicine today. The reality is that is significantly shrinking the already dwarfing, the already downtrending amount of physicians that are in independent physician practices. So, and again, to have a physician that's an independent practice, that they run themselves, that they're not controlled by a corporation, that they can tell you unabatedly whatever recommendations they actually have for you without getting in trouble by their employer or without getting in trouble by the insurance company or what have you. That's where I think that the highest value, lowest cost care can be found in this market. And let's compare that to the alternative, the CEOs of the healthcare system, the hospitals, and et cetera. So HCA, ultimately the CEO of HCA, Sam Hazen, last year made $84 million, which was actually 4 times what he made in 2019. And so, HCA early on, I'm not sure if you saw it in the news or not, but there was a significant amount of news press about HCA laying off nurses or furloughing nurses at the beginning of the pandemic, and basically getting rid of staff. And obviously, to some extent, nurses, physicians, all the clinical staff, all the healing team members were the people that have gotten us through to a large degree this COVID crisis, and tried to keep us all healthy and try to do whatever we could. Obviously, there's certainly a significant amount of censorship out there to where some things are not allowed and not able to be talked about, and that's to some extent actually even above these big businesses, but obviously with big tech and what have you. But again, whereas physician practices are closing and we're getting less and less in reimbursement, these CEOs and actually even the hospital systems, this is not Sam is not alone. This is actually even before COVID, over from 2014 to 2017. You can see these CEOs of nonprofit hospital systems are making millions and millions and multi-millions of dollars. And so, from that standpoint, just another source where money is being pulled out of the system, pulled away from patients, pulled away from reimbursing the folks that are actually providing care and providing the value. And let's just talk about those non-for-profit hospitals a little bit more. Actually non-for-profit is a tax designation basically, and usually that is tied to some amount of charity care and community service. But basically what a lot of these hospitals do is that they balance out their profits by lots of red, and where they get that lots of red without actually, undergoing a big loss is that, I don't know if y'all saw the recent Wall Street Journal article where at this exact same hospital in California, you could get a C-section for somewhere between $6,500, that's $6,500, and $60,000, depending on which insurance company you had. That'd be like going to McDonald's and trying to get a Big Mac, or no, that's not McDonald's. Trying to get, actually that is, I'm sorry, I was thinking Whopper. But so yeah, going to McDonald's and trying to get a Big Mac, and depending on, which credit card you gave them, they would charge you different prices. From that standpoint, these inflated prices, the not-for-profit hospitals basically create a way for them to have significant amounts more loss by what's called uncompensated care, which is basically where the hospital basically subtracts any of the collections that they actually get paid for from the charges that they actually charge of these inflated prices. And basically any difference is basically documented as an expense in their accounting. And so that gets sent to Washington and ultimately becomes more Medicare payments in the following year. And so you can very easily see where some of these CEO bonuses can be hidden in losses because that balances them out. But again, to some extent, that's usually tied to some type of community service and what have you. But we'll see. This was a recent post on Twitter, and I apologize I couldn't get to the actual article. But a recent post on Twitter from the American Association of Physicians and Surgeons, where basically they looked at how much are these not-for-profit hospitals actually giving out in charity care. And what we found is that they really only gave out about 2.3% of their total expenses in charity care. And that compared to their counterparts, the either for-profit hospitals or the public hospitals, they were actually giving out less charity care than those other folks. And so there's this debate of, they're not paying taxes, they're giving out less back to the community, and they're getting this significant kind of kickback from the government. Obviously their CEO is making $84 million a year, or at least did last year. I mean, there's obviously some big disconnect there. And so, that's a big problem. Diving further into that, this is more about the insurance companies and looking at since the Affordable Care Act, this is from 2010 to 2018. We see that if you look down in the red box here in the lower corner on the right-hand side of the screen, we see that between 500 and 900% growth in stock prices from these big insurance companies, Blue Cross, United, Cigna, Anthem, Humana. And remember, that's significant amounts of money that it's being sucked out of the system and going into profits for United. or sorry, going into profits for these big insurance companies and to these shareholders. Remember, United Healthcare made $22 billion in profit last year in the middle of a pandemic. And so, from that standpoint, there's a significant amount of money that's being sucked out of the system and being taken away from patients and taken away from the healers that are actually doing all the value work in the healing team itself. This actually just looks at, similarly, basically between 600 and 1200% for these companies between 2009 and 2020, the growth in their stock prices. And when you compare that to the S&P 500 and the Dow Jones, you're looking at, 400 to 500% growth, right? So they're making significant amount more and providing significant amount more returns than even just the averages for these bigger corporations that are in the main portion of the stock market. And so that's a problem. What compounds that is that, to a large degree, I keep telling folks, and I even was on a call yesterday where, folks were talking about trying to make change and trying to lobby and trying to take advantage of folks like Charles who lobby and rub shoulders with folks and try to make change. And my question to them was, do you really think we can make change in that manner? And my thought about it personally is that the reality is I'm not sure that we can. We can certainly try as best we can, but the reality is it's basically like a David versus Goliath system right now, right? So this is just 2020 numbers. Hospitals, insurance, HMOs, pharma leveraged about $650 million in lobbying in 2020, whereas health professionals leveraged about 87 million. So you're basically almost a $600 million gap. And I think even if I was a politician, I mean, if it was a $600 million gap, I like to think of myself as a high moral person, but to some extent, $600 million is $600 million, right? And so, from that standpoint, there's a significant difference in our ability to leverage and lobby. And obviously, again, we can't try to, in my opinion, we can't try to beat them in their system where, basically you're shuffling around. I always kind of describe it as a money laundering system between the government, the corporate hospitals, the insurers, et cetera, pharma, where they're all kind of just passing around money to each other. And it's hard to break into that and overturn it and beat them in their own game, which is where I think we have to be like David. And this is where the cash market, the free market comes in, because we can basically cut them at their knees, like Jeff said at the beginning, and really just kind of cut out them and go directly to patient, try to deliver them the lowest cost care we possibly can, and try to return the highest value to them for their dollars, and also potentially save them money in the long run to do so. And this is just to beat the horse a little bit more. This is over 20 years. Just the pharmaceutical industry has leveraged $2.6 billion in lobbying money. This goes into a little bit of the problem with the corporate systems even further. You can see a lot of these corporations on the slide here. Unfortunately, a lot of physicians are being replaced by nurse practitioners or PAs, non-physician providers. There's certainly a lot of great nurse practitioners, a lot of great PAs out there. But unfortunately, there's also a significant problem with the Board of Nursing where they're not holding any standard of education at this point. And basically there's practices out there where there's 100% acceptance rates into nurse practitioner school. You don't even have to be a nurse anymore. Whereas in the past, you basically had to be a nurse. You had to have, a couple of years of critical care experience, and then you had to go to, like a 2-year brick and mortar school. Now, some of these folks are doing school all online. They were never a nurse in the beginning. And ultimately they're getting as little as 500 clinical hours. And remember, unfortunately, if a lot of these folks are donating to politicians, they're donating to the nurse practitioner associations, which are, increasingly getting free practice authority throughout the country. I think it's something like 25 states now. The problem is that you're basically putting yourself in a situation where you're potentially getting a significantly less experienced either provider or physician. Obviously, if they're replacing physicians, then they're to some extent significantly less experienced, unless they already have a decent breadth of experience out in the real world after their training. And we'll talk about that a little more in a bit, but even there was a hospital recently out of Wisconsin that basically got rid of all their anesthesiologists and went to directly CRNAs. And that's pretty much entirely what the hospital is working with at this point, which, to some extent, anesthesia, I used to date an anesthesiologist a while back, and the reality is that anesthesia is great. It's easy to put somebody to sleep. The reality is you really pay them to wake you back up and make sure you make it through whatever surgery you're doing or whatever procedure you're doing well, and unharmed, right? From the heart and lungs and from your brain standpoint, making sure perfusion's there and all that stuff. And so, unfortunately, the reality is this Dunning-Kruger effect is something that's basically, you get to a certain level of education, you think you know it all. And I think for a lot of physicians, it's kind of, before you get to medical school, you kind of think you know a lot. And then you really get into medical school and you think you're basically sipping off a fire hose because there's so much information. And actually, even to some extent, again, probably in residency, this is not meant to be offensive to folks. This is not meant to be degrading of physician assistants or nurse practitioners. This is just really, truly meant to be an illustration of the difference in the hours of experience that folks have, right? And so to be a practicing physician autonomously by yourself, you have to have at least 15,000 hours of clinical experience through medical school and residency, at least 3 to 5 years, potentially even longer of residency training. As a physician that graduates medical school, you're at about 5,000 to 6,000 hours of experience. Unfortunately, in the United States, you cannot practice as an independent physician at that time. You have to go through residency training in order to be able to practice on your own. And unfortunately, since about 23 years until recently, they just approved an increase in slots about 1,000, and there's some legislation coming down the pipes that maybe we're going to increase another 14,000 over 7 years. But unfortunately, there's been a 23-year hiatus on any increase in residency slots, to the point where actually 6,500 physicians almost on an annual basis don't have a residency slot. And so they basically made it through medical school in good standing, but they can't continue on with their training. They either have to wait a year and reapply, or they basically which obviously to some extent takes somebody else's spot that next year, or basically they're pivoting into some other type of situation where or some other type of business to be able to create some cash flow for their family. And obviously that's a big problem. We have these people hanging out, they can't really do anything. Yet, unfortunately now physician assistants and nurse practitioners, to some extent, they come out of training with 2,000 hours for a physician assistant and about as little as 500 for a nurse practitioner, like we talked about with these kind of quote unquote diploma mills that are out there now, where they have 100% acceptance rates. You don't necessarily need to be an RN first, and basically it's all online, and you really only need a very short number of clinical experience hours. Unfortunately, I think we all know that there's a significant amount of difference between 500 and 15,000 or 20,000, to the point where the reality is I don't think any marathon runner that's out there pretends that they're going to win the Boston Marathon with 3 to 13% of the training, which is basically what 500 and 2,000 represent of 15,000, right? I think, and I absolutely will take this to heart, that all members of the healing team have value, but the reality is that there's a significant difference. And remember, the corporations that are out there, it's profitable for them to try to replace physicians with nurse practitioners and PAs because they're less expensive, right? So if you can cut out $300,000 in a physician's salary by essentially replacing them with a PA or a nurse practitioner, then you save yourself $300,000 in overhead, like we were talking about for physician practices. But the reality is there's a difference. We're not the same. And so that's where you kind of hear about a lot of physicians talking about the term provider. We kind of, I think big business and big corporations, big hospitals kind of lump physicians and nurse practitioners, PAs, into providers, all of us. And to some extent, I guess, yes, it's a descriptive term, but the reality is, again, we're not actually the same in the grand scheme of things. And so to some extent, it's a way for them to kind of start to, basically kind of equate us and then kind of replace the cogs in the wheel to a cheaper alternative option, which is unfortunate. One of the other things that they do nowadays is that they're basically vertically integrating. So you've heard of maybe potentially pharmacy benefit managers, specialty pharmacies, and obviously the providers or physicians. The reality is, if you look at this far left hand, United Healthcare, I hate to pick on them again, but they're up there. Optum Care, we'll see in the next slide, or actually as we saw earlier, they're the largest owner of physicians in the country. OptumRx, which is their pharmacy benefit manager, actually made more profit for United Healthcare last year than any other subsidiary of United Healthcare. And actually, unfortunately, pharmacy benefit managers were supposed to help decrease costs, but that's not really what they're doing. In fact, actually in Ohio right now, I literally just saw an article before we got on this talk. In Ohio, the Medicaid program in Ohio actually is about to save $200 million next year by getting away from the pharmacy benefit manager that they were using last year. And so, obviously, again, $200 million, that's no small change. And obviously, again, we're talking about United Healthcare owning, 50,000 plus physicians, making lots of money with their pharmacy benefit manager. And remember, again, they made $22 billion in profit, not just net, not just gross income, but in profit last year. And so this vertical integration, to a large degree, it's not necessarily a monopoly, but it's certainly, approaching that type of scenario where these folks are having control. I personally, again, I think there's a significant conflict of interest, and it needs to be looked into closer by the federal government. But obviously that's not anything I can control at the moment. But contrasting that, so shifting gears a little bit, right? So we talked about these corporations and a lot of the problems. The grand scheme of things. Now, obviously, every single physician does not embody these characteristics, but I think for the most part, most physicians try to do their best. We're all human. We try to do our best to embody these if we can, right? So we're hardworking, we're intelligent, empathetic, kind, responsible, caring. I think the last two are probably the most important, is that, altruistic. Yes, we make money based on the services that we offer, but the reality is if you're not altruistic at all, there's no altruistic bone in your body, you'll never make it through the training in order to be able to make money. Because the reality is you have to be self-sacrificing. You have to sacrifice to some extent your time with your family, and you have to sacrifice your nights and weekends to a large degree to be able to service patients where they're at, whether they're in the emergency room or whatever type of care that they need. And so, to a large degree, these are the characteristics we embody as a cohort. But there's significant problems. We already talked about the problems of practices, independent practices shutting down, and those types of issues. This slide really just talks about the debt that new physicians are reaching into to be trained, right? And so the average debt in 2020 was $250,000. Again, that's most people's mortgage. And so you're basically coming out of school with a mortgage without even actually having any property associated with it. And actually, 53% are over 200,000. There's basically about 15 to 20% that are actually over 300,000 in debt. And so, this is a significant problem, especially as, reimbursement and payments to physicians, or potentially physician jobs being eliminated, continue to occur. And actually, if you look at it, physicians are actually only paid 7.3% of our actually total national health expenditure. And so, if you wanted to wipe out all 1 million physicians as far as their payments or their salaries, you basically would decrease the national health expenditure from 3.6 trillion to 3.3 trillion. Not a very big dent, right? And so yet the part of the healing team, right, along with the nurses and et cetera, and nurse practitioners and PAs, all the great people that help you out when you actually need care, the reality is that we provide all the value, yet, there's a significant differential, and there's a significant amount of money that's going elsewhere. And we already talked about that administrative bloat that, ultimately is there, that really isn't providing a whole lot of value to patients. This just talks about another stressor where, specifically Medicare, the physician reimbursement for Medicare is actually not even kept up with inflation. And if you look at the increase in costs versus kind of the stagnant or maybe minor increases in the Medicare payments, physician practices are actually at a loss of 19% based on the increased costs and the essentially kind of stagnant or maybe minor increases in payments. And so just another stressor that illustrates part of the reason why independent physician practices are going out of business or being absorbed by private equity or being absorbed by corporate hospital systems. So what this means for the traditional system is that physicians are basically on a hamster wheel. And the reality is that the only way you can try to increase your income is to see more and more and more patients, which is classically what you hear patients describe as, oh, I only saw my physician for 5 minutes, that they were in and out, and I didn't really get much time with them. There was, decreased value because I didn't get to ask a lot of questions that I wanted to, and this type of thing. But unfortunately, with all these different stressors, physicians are having more and more difficult time staying independent and staying free of the other systems. And even within the corporate systems, they still have to, to some extent, see more and more patients and spend less and less time with each patient, and the value decreases for the patient because of that, unfortunately. We're going to skip through this slide just in the sake of time, but this just talks about, a little bit about, kind of the loss and autonomy of control and why physicians don't necessarily love their jobs as much as they used to. I think, loss of autonomy and control of their actual environment, and to some extent decreasing compensation, and some disrespect from the folks that own them, their employers or their administrators, certainly goes a long way there. Along with that, given those stressors and given the stress of managing patients and dealing with patients' death, if for some reason that happens, or potentially all the bad things that could potentially happen to a patient, obviously our entire goal is to treat you, get you well, and not have problems ever. But that's not the reality of life. Physicians are humans too, and unfortunately, the physician suicide rates are double the general population, which I think is twofold. Obviously, it's a very high stress, work environment in some instances. There's certainly fragmentation of sleep if you're on call and you're getting called in the middle of the night, and we know how important sleep is for you. But also remember, actually, they're basically, kind of disincentivized to actually get help if they need help. Obviously, I think certainly that it's important that people are competent and within sound mind to be having the responsibility of helping someone. Myself as a surgeon, certainly I'd want to make sure my surgeon has a sound mind and is well rested and et cetera before they ever operate on me or touch me. But the reality is that physicians, from what I've been told by other folks, if you're going to seek care, you should probably go to the next state over, and you should probably pay cash, so there's really no record or trail of it. Because the reality is, unfortunately, what happens is if you go and seek mental health services, then you have to check boxes on the next, job application or the next license application or what have you, to say that you actually, sought some care for whatever problem. And ultimately, to some extent, you can kind of potentially be labeled as kind of a what's the word I'm looking for? Basically, a tainted physician or what have you, to some extent, that you're not necessarily competent enough to be handling care or handling your job, which is unfortunate. So, shifting gears a little bit away from physicians and talking specifically about patients, this is a graph specifically of premiums for health insurance. The blue lines are single payers. The orange lines are families, right? And so you can see incremental increase in premiums over the last 20 or so years. Certainly in 2020, the average was about 21, a little over 20,000 for families as far as premiums, and probably about $7,500 for single payers as far as the health insurance premiums that they're paying. Remember, these premiums are not associated with actually any care associated with them. This is just what you're paying to have quote unquote insurance, right? And so the next step this is looking at 2021, which the premiums for families, for a family of four, has basically gone up to about $28,000. The reality is that most people don't actually ever see that value come away from their paycheck, right? You see this small value of maybe $6,000, but remember, your employer is paying a significant portion, 50 to 70% of that or so. And remember, that's part of your compensation. And so if they weren't paying that, theoretically, they would usually have to pay you, a higher salary to kind of compensate for your benefits that you're not getting. And so to a large degree, a family of four, at least based on these averages, is actually paying about, basically buying a new car and insurance premiums every year. And obviously that changes with every plan and et cetera. But I guarantee you, most people in the United States are not buying a new car every year. And so, they're basically, as we look at this next slide, they're basically losing, this is a single payer, $5,000 a year, right? Over 10 years, you're basically losing about, upwards of 70% with kind of fees and potentially, interest and et cetera. Whereas if you were to put that same value into a health savings account, you basically could actually net $170,000. So you go from 70,000 in the negative to zero to 100,000, assuming some certain things like a 10% return or annual return and what have you, with your investment. And that's a significant difference in the amount of money that's in your capital, in your pocket, versus the amount of money that you pay just to have quote unquote insurance, which whether or not that actually gives you access and actually gives you good, appropriate care, I think we all can agree is a different story. Skipping ahead to kind of the later years of life, a lot of people think that Medicare for all is great and Medicare in general is great. The reality is if you don't have a supplemental insurance or essentially kind of an addendum to your Medicare, then the average couple, so two people in Medicare years from the age 65 to potentially 85 or maybe even up to 95, depending on how long you live, so 20 to 30 years, this is based on AARP data, the average couple will spend between $230,000 and $340,000 out-of-pocket medical costs. And most people don't even have that saved for their own retirement, let alone just for medical costs. And so, that's where there's a problem. Getting back around, there's a significant amount of bankruptcies in the United States, 775,000. Actually, 2/3 of that is associated with medical bills. 520,000 bankruptcies in the United States as of 2019 numbers were associated with some form or potentially all of medical bills. And the unfortunate part about that, again, is that 60% of those people, or 312,000-ish, actually have insurance. And so, again, that kind of also goes back around to what I mentioned earlier about these not-for-profit systems where to some extent they're getting, they're supposed to be contributing to the community. They're not necessarily given as much charity care as they're supposed to. They're getting, basically free taxes. They're also writing off a significant amount of what we call kind of uncompensated care and getting more money back from the government. But at the same rate, to some extent, when folks aren't paying their bill, these folks are being sent to collections. And so, yeah, they may not pay for their medical care up front, but if you get sent to collections and all of a sudden they're going to foreclose on your house to collect the payment, well, then you're paying for it on the back end for sure. And so that's a significant problem. This one hits me real hard. Obviously, I don't think that anybody should go bankrupt or lose their home or what have you for medical care. Unfortunately, the problem with that is that, if you have Medicare or some of these other government insurances or even some of the other ones, if you walk into a physician's office and the physician wants to give you charity care and basically write off your services, if you have some of these specific insurances, they can't actually do that. They can't give you free care and they can't walk away from that. And so, that's a problem. And they can't even turn around and try to help you from a health standpoint and a financial standpoint, which is sad. So I think, hopefully you've learned a little bit along the way here. We're wrapping up a little bit. I think America, in my mind, was built on the dream of creating a small business and providing for your family. And that's kind of the America dream, the opportunity of doing so, right? I would say that a fact is that Americans, unfortunately, love their comprehensive insurance. But I hope that I've illustrated for you that insurance does not equal care and does not equal even access to care, unfortunately. And so I hope that you can see that Americans can save millions of dollars by self-directing their medical care and also actually supporting small independent physicians at the same time. And looking at that a little bit further, how do we turn this ship around? This is really what are the options out there to get away from the traditional model? Well, basically, there's a few of them here that we'll talk about. Ultimately, direct primary care is actually a very new thing within the last 5 years or so. But it's becoming a very hot way for primary care doctors to work with their patients directly and avoid, whether the patients are uninsured or whether they have very high deductible plans or, et cetera, they can basically charge a very low cost membership. The patient gets the added benefit of not necessarily being in a practice where the physician's on a hamster wheel and they can only spend a certain amount of time with them. They get more time, they get more value. They also get access to potentially email, to potentially text, to potentially telehealth for free, and potentially even some blood tests for free, where, you know, obviously you can get a significant amount for potentially even less than your cable bill every month. And certainly less than your premium, most likely every month. That's just going away to the insurance company, which, remember, to some extent is just going away to the shareholders to a large degree, at least the profit part. Then we talk about sharing programs. You know, I really love sharing programs. I think that they are a great solution for what should be the protective insurance that was meant to be for us. And what I mean by that is really catastrophic coverage. So, you know, basically the risk of catastrophic problems is negated by, you know, certain deductibles, kind of just like your own insurance, but otherwise outside of the bigger problems, then you basically become kind of a cash buyer and you self-direct your medical care. And so the rest of these are basically options to help with that cash buying part. And remember, the beauty of being a cash buyer, number one, from a patient standpoint, you're able to choose your physician, you're able to choose who you see, where you see them, you know, what formats you see them in, and you never have to listen to an insurance company denying your surgery. Actually, I just had a patient email me or message me on social media today where he was very bent on and interested in getting a certain procedure, and basically his insurance said he couldn't get that, and they basically recommended 2 other procedures, which actually, when you look at the guidelines from the American Urologic Association for the problem that he has, both of those procedures are actually out of date and should not be used anymore based on the American Urologic Association guidelines. And so, you know, unfortunately from that standpoint, he's left kind of like, what am I supposed to do? And trying to figure that out. But so these other options, health savings account, we kind of highlighted a little bit. You know, the beauty of a health savings account, you can put in, you know, a certain amount, like $6,000 or $7,000 a year per person. They can be invested and they can accrue interest, as we talked about. The health matching accounts are also something that's a really great option. I love these. I think there's something that not a lot of people know about, but basically you pay in a certain premium for a 3-year investment period. And then basically at that time, the value actually doubles. And so you have essentially kind of a quote unquote kind of savings account or at least an account that you can use for your out-of-pocket healthcare costs. Then there's also other folks out there. This is from the Citizens Health folks that are looking at basically trying to create a combination plan where it's basically your HSA potentially associated with crypto, and then also a sharing and also essentially kind of a financing or a credit option kind of all together rolled into essentially kind of one card, one account. And then finally, like Jeff mentioned at the beginning, the Wow Cash App, which I think is, you know, a great way to be able to find physicians or other providers that are out there online through an app in your own home that offer the services that you need, and you can shop around prices much easier, right? And so you don't have to call every single office and ask what your price is for this or what your price is for that. You can go and find all the folks that are on there that offer whatever service, and you can look through, you know, kind of the different prices and what have you. And so, you know, all of these things are a way for us to turn the ship around, to cut out the big business and the government, and essentially kind of self-direct your care. The beauty of it is, from a physician standpoint, you know, you walk into my office and you want to pay cash, I love you right off the bat. I'm much happier dealing with that because I already know I don't have to deal with that extra 30-40% of overhead trying to get paid, whether or not I actually get paid. And the other part about that is different than a lot of other businesses. Physician practices in the traditional system, on average, there's a thing called a business term called accounts receivable, which is basically from the time that service is delivered, how long does it take you to get paid for that? For medical practices, that's 45 days on average. On average, some of them are up as high as even 90 days. And so imagine if you walked into McDonald's and you try to get that same Big Mac, and McDonald's didn't get paid until 45 days later. Do you think they'd really give you the Big Mac? I'm not sure that they would. And so, you know, again, that's another stressor on independent physician practices that can be negated by, you know, essentially becoming a self-director of your medical care. And again, obviously, a lot of folks are very happy to return that cost savings to you as the patient, and again, try to give you the lowest cost, highest value care. So I think in summary, if the physicians and the patients stand together, and I think that's very important because physicians cannot do it alone. Again, I already mentioned to you, it's a David versus Goliath situation. Physicians can't change this by themselves, but if physicians and patients stand together, then the game is over for the big business, big corporations. And I would, again, encourage you that the highest value, lowest cost care on the market can be found via working directly with an independent physician practice. Thank you so much for all your time and listening through the talk. I'm happy to entertain any questions at this point.
Okay, very good, Jared. That was very good. And yeah, of course, you did a great job of overemphasizing the reality of all of this.
Yeah.
It's good that you use that terminology, own them, because that really is the truth of it. Even though it seems like they're not owned, they really are. And that's the shame of it, because like you said, the person's there to help me, and they're looking to somebody else to intercede. Making you remember, just to make a little humor out of it, there was a great episode in The Simpsons where Marge is in the hospital and the family's all crowded around the bed, and the doctor comes rushing and he says, "You're going home today." And they're all like excited, and she goes, "Fantastic, am I cured?" And the doctor says, "Well, according to your insurance company, you are." And so that's kind of what you're describing. And so that's why when they get into that WOW app or these other methodologies, the doctors say, I finally get to go, because like you said, most every doctor I've ever encountered, yeah, they want to make some money. Who doesn't? But that's not their purpose, because they got to put up with, like you said, a lot of sacrifice. You see people suffering, or you see people dying, or surgery where you're watching blood and whatever. So they have to have some empathy in there. Otherwise, why would you do it? And yet, they just can't seem to make it work without being told by everybody else how to run their own business. It's unique in America. They don't get to set their own price, and everyone tells them what to do all day long. So it's very frustrating. You can see why ultimately they would commit suicide. And from a layperson, you'd think, well, these are smart people. Why would they commit suicide? Some maniac or whatever. But who knows what they're up against, like you said. And then concurrently, since we've been involved with this growth of the insurance companies, they're trying to get more and more people to have insurance. But what's happening? Less and less doctors. Well, that sounds like a recipe for success right there, I'm sure. So let's grab some questions from the gang out there. And I see Charles has got his hot little hand up in the air.
Well, thanks, Jeff and Jared. Fantastic presentation. I think we all want that final slide, which labels the cartel exactly as it is. The bucas, pharma, the hospitals. One group we haven't mentioned that we've learned with our Rosetta advisors over the past month are the big brokerages too, the Mercers, the Aons too. They're including with HR to keep the bucas in control.
Right.
So thanks for that plug at the end. That's a great solution that you mentioned for us to become cash shopping patients. We have some great surgeons on the call, and I would like to put on the spot any of them to raise their hand or just blurt out. John Taylor, independent surgeon, Paula Muto, Uber Doc, Dr. Campbell. The three of you, you guys have spoken before over the years with us. What are your thoughts, what you've heard tonight?
Well, before we let them jump in, I got one person who's had their hand ahead up to all of them, which is Sam. So let him slip in a quick question first, and then we'll open it up.
Hi, can you hear me?
Yes.
Hi, thanks for the opportunity. Jared, great presentation, and I love everything you're saying. I completely agree with you. I have a quick question, and then I have a follow-on question. The quick question is your practice entirely cash, or is it a hybrid practice with a cash and risk-based payment model?
That's a good question. So I'm not yet open. We are currently in the building phase, but it's going to be entirely cash. So, I was planning to, and actually I even, kind of reached out to Keith Smith and Paul Thomas and some of these other folks that are out there doing, kind of direct market or either direct surgery or direct primary or what have you already. And their comment was, you should probably establish the business as an independent physician first, and then toggle. For me, especially with my real estate background, I'm actually going to work pretty quick and have been working over the last 6 to 12 months or so to essentially compile a cash flowing Airbnb portfolio in the rental space. And basically I'm going to use that, basically as a protection mechanism, and then basically open entirely cash based. Obviously, to some extent, unfortunately, as a surgeon, different than, Paul Thomas or some of these other primaries, it's a little bit difficult, because if I really want to build out the entire thing, especially if I want to build out where I have procedural space in the office, but also have essentially a surgical suite where I never have to walk into a hospital or what have you, because remember, they're going to make me contract with insurance, and they're going to make me tied to Medicare and all this stuff. If I want to do that, it's probably going to be about $500,000 at least from a capital injection from just durable medical equipment. That doesn't even count the space itself. And so trying to line up all the bricks for that, it's been a little bit difficult, but we're on the right path. But quite honestly, I mean, Jeff kind of alluded to it. The ownership model, or being owned, and to some extent breaking free of a corporate hospital system and not being owned anymore was great. But then I start to realize, especially as a solo guy, these big insurance companies basically just bat you around like you're a little mouse and play with you, and they don't really want to pay you what you're worth, and or even pay you what they're paying some of your competitors, right? That maybe have more leverage by more doctors. And so from that standpoint, my background to some extent is German Irish, and I'm a Taurus, and my beard grows in red. And unfortunately that means that I'm a little bit stubborn sometimes, but the reality also is I know when people are pulling the sheets over my head. And so, I just can't do it to live in that system right now. So I'm trying to get around that by just going direct cash. Because the other part about it that didn't make a lot of sense for me was, let me contract with these insurance and build up an entire insurance-based practice, and then turn around and switch that to cash, maybe over 12 months or so, like some others have recommended. But basically, a lot of those people who are tied to their insurance, they don't want to let that go. And so I think to some extent, to a large degree, you're looking at a little bit different subsets of the population for those two types of business models. So that didn't really sit well with me as far as that goes.
Great. Congratulations. You're a real trailblazer. Well, the follow-on question I had was that most specialty practices are independent practices, depending on the specialty, some more than others, but by and large, there are a lot of independent specialty practices that have a risk-based model, but they also have the freedom to set their own cash prices, and many of them do. Speaking with a OBGYN in Connecticut, I'm in San Francisco, so this is just part of me poking around. An OBGYN who charges $25 for a pap smear for cash patients. And she said most of her patients' copays are higher than that.
Right.
And I said, well, why didn't you just tell them to pay cash? She says, I can't.
Right.
But if they ask me, I'll take the cash and I'll give them the price, but I can't volunteer that information if they're carrying insurance, because it's just, going to upset the insurance companies. So I think part of the problem is that there's a lack of awareness amongst people that they can get cash prices. And she said that's the problem she has. And many others I've spoken with, is that people aren't aware that they can actually go out and get cash prices that are much lower than what they're paying in co-insurance and co-pays and things like that. So how do you address that problem? Because I think the real issue, like you said, it's the David and Goliath model. Trying to change the system is not going to work, but I think can change people more easily.
Right.
But there's really no mechanism. Now, the WOW app is great if people find out about it and start using it, and that's a good start. But I think the real problem is changing people's behavior and awareness to drive this change that we're all talking about.
Yeah, I mean, I think that's an excellent point. Thank you for providing that to us. But I think that part of that too is, to some extent, just like physicians are fearful of jumping into the cash market, patients are fearful of letting go of the parachute of the insurance model. Right. And so I think that's where, talks like this, maybe Charles and I have to drive around the United States and just have groups all over the place and talk to people. I don't know, but I'm happy to do whatever I can to start to change people's minds. Actually, even in the real estate space, I think I kind of made a decent amount of heads turn when I started talking about, a lot of folks in the real estate space are very familiar with what's called a self-directed retirement account, or a solo K. But I started to kind of compare that to essentially kind of you even heard me in the talk, self-directing your medical care, and people significantly realize the benefits of doing that from a real estate space. So, I think everything I try to do, even in my medical practice, my surgical practice, everything I try to do is trying to relate it to things that people would understand, right? I can sit there and talk about penile implants all day long, but the reality is if I can tell you that you have a hole in your tire and the tire is flat and the penile implant is basically like a new inner tube for your tire to replace the need for the tire to be pumped up again and still fulfill the same function, then people grasp that much better, right? And so, I think that's where, really trying to start to get to people on their level and also, kind of realizing the significant waste that's in the system, right? Because I think we all know that Jeff and I and some of the other folks were talking about in the beginning, some of these webinars being censored and managed by big tech and what have you. I think we all know that the mainstream folks, the government, the mainstream media is probably not going to be the ones that are promoting all this stuff to get the word out there, right? Because to a large degree, obviously that's risky for them as well from a standpoint of the big corporations that they're associated with. So yeah, I think that the best we can do is start to educate everybody that we possibly can, and really show them that there are actually other options that are much better for them, and they can still have the same protection. I mean, if you can have a sharing program where you have the same protection of your catastrophic medical coverage, and actually you can get your passenger for $25 rather than however much you were paying from your insurance, that's huge, right? And so again, it's to some extent freedom, but also trying to balance out the freedom and solve the fears at the same time, I think is probably the biggest thing that folks need to be educated about.
Yeah, I think education is a key word, because I think most folks aren't. You have financial literacy programs and seminars and things like that. I've never seen one for healthcare, and most people don't have any idea how. I'm with you. Just let me know.
Right. And I think that's key, actually. Sam, one of the things that I always talk about with my real estate folks is that, the majority of the country does not have a financial education. Actually, even if we talked, probably a year and a half, 2 years ago, before I kind of got into the business stuff and the real estate stuff, I would have told you that I was one of the highest educated, ignorant, financially educated people in the country. Yeah. Because, we just don't get it in our traditional system unless you find it somewhere around the way, or unless you get it from your parents or what have you. And I think taking it to the next step, healthcare finance literacy is significantly even worse, right? So that's where, yeah, absolutely. I even talked about that with one of my real estate coaches last night was, maybe we should create a training program and start to educate people about this stuff and build cash buyers for everybody across the country. I mean, I'd be happy to do that.
It's a great place. That's a great place to end it as we're running past our time. And again, that's part of what you're trying to get us to right now, in that, how am I going to have financial literacy about healthcare when I don't even know what anything costs? At least with real estate, there's Zillow. So there's a level playing field. Like you said, it's all, you're a little too short. We're going to charge you a different price than that tall person behind you for that burger. So yeah, that's a big part of us getting to that transparency. And then the market can do what we're talking about here. Right. So this is great. And thank you so much for today.
Yeah, thank you.